Hey, everybody. This is Austin Kaiser, the clinical educator over in California, coming to you today with the Stable Programs Cardiac Module. We're going to go through parts 1 and 2. And without any further ado, we're going to get going. So part 1 is all about the physical assessment of the newborn in regards to a kid with congenital heart defects. And so we're going to go through each one of these areas of the body in order to show the differences between a normal neonate and a CHD neonate. So first thing, when looking at the respiratory rate, we know that newborns have a normal respiratory rate of about 30 to 60. Normally, they have an easy breathing effort. If you are a tachypnic baby with a sustained respiratory rate greater than 60, then we know that that's abnormal. If the kiddo looks like they're working really hard to do it, like they're labored or something like that, then oftentimes that's going to be due to a respiratory issue. But if they have a sustained tachypnea and they look like they're not too unhappy about it, so they're, quote, comfortably tachypnic, that is often that's often one of the very first signs of a congenital heart defect that we see in these kiddos. As always, if you have a bradypnic child, a kiddo who is breathing less than 30 times per minute, then that is a sign of impending respiratory failure. And if you have gasping, then we need to go ahead and just take that airway because that's an ominous sign of future death. Common signs of respiratory issues in regards to congenital heart defects and congestive heart failure are not unlike any other pulmonary problems. So you're going to have those labored breathing. You can have intercostal retractions or substernal retractions. You can have grunting and nasal flaring. So their respiratory effort is not necessarily indicative of one disease process versus the other in these CHD kiddos. Normal heart rate for these kids is going to be anywhere from 120 to 160, which is just a completely normal neonatal heart rate with a little bit of fluctuation down maybe into the 80s or up to about 220. Remember that SVT in these babies is not above 180. It's above about 220 beats per minute. And abnormal, we have several things that we're going to look at. First, a sustained bradycardic child is going to be some sort of pathology going on, be it some sort of severe acidosis or hypotension or infection or some sort of hypoxemia. It's important when we are looking at the heart rate to differentiate between a sinus bradycardia, meaning that this is potentially a reversible cause from something that we did, like intubation, causing an increase in vagal tone, or maybe putting in a central venous catheter accidentally into the heart and causing that increase in vagal tone. Those are things that we can fix very easily. Whereas if we have a kiddo who has a third-degree block, that's definitely going to be some sort of pathological issue. I'm not going to go into how to identify a third-degree block. I'm sure that everybody listening to this certainly can. Normally with a third degree, you have those ventricular rates that are like 45 to 80 beats per minute, unlike the adult whose ventricular rates are normally 15 to 35 when we have third-degree blocks. Common cause for having a third-degree block in the newborn is a mom who's born with lupus. If the baby is, you see that term at the bottom of the screen there, if the baby is hydropic, meaning that they have like systemic edema, typically because the mom's autoimmune disease, their lupus, the baby's going to be pretty critically ill, and oftentimes you'll see that third-degree heart block present in those babies born to the lupus mothers. On the flip side of the bradycardia coin, we have tachycardia. Tachycardia in a kiddo in a newborn is defined as a heart rate that's sustained at greater than 180 beats per minute. Much like in the adult population, we want to look for signs of shock in these kiddos. Just like differentiating bradycardia, being able to differentiate tachycardia is important. Being able to know the difference between a sinus tach, meaning a heart rate of 180 to 220 with very obvious P waves, and being able to identify SVT is obviously pretty important. They do have these little sound notes right here. I'm gonna press play on it and see if it gets picked up on my microphone, but I will not find out until I get into editing here. All right, pretty obvious the difference in speed between a normal heart rate of 140, which is just a normal kind of a sinus rhythm for these newborns, versus that SVT at 220 beats per minute. All right, next vital sign we're looking at is going to be blood pressure. You're going to measure it the same as you would any other person, be it a properly sized non-invasive blood pressure cuff or some sort of arterial cuff. Obviously, with children and adults, we can have central lines, arterial central lines through the radial artery or through the femoral artery. With babies, we do additionally have the umbilical artery available to us as well through a UAC line. As always, in any of our child populations, hypotension is going to be a very late sign of decompensation. And so we want to evaluate really heart rate and respiratory rate and skin signs and capillary refill and all of those other things before we start to see those drops in the blood pressure for these kiddos. Know that in the normal newborn, because of their patent ductus arteriosus in the first several hours of life, that typically the blood pressure in the legs is going to be a little higher than the blood pressure in the arms. It's pretty insignificant, and oftentimes you're probably not even going to notice it. But if you do notice that there's a significant difference between the arms and the legs, meaning that the arms have a much higher blood pressure than the legs, you have to start thinking about the fact that there may be some sort of obstruction for the blood being able to travel down through that aorta. So you may be looking at a coarctation or even an IAA baby, that interruption of the aortic arch, which we'll talk about during part 2 here. Skin signs on babies, we're looking at just a pink baby as the perfect healthy baby. If we have some peripheral cyanosis, oftentimes it's not a big deal, maybe associated with feeding. If we have circumoral cyanosis, kind of same thing, maybe associated with feeding, typically not something that's going to get my spidey senses really going on a sick baby. But if you do see that circumoral cyanosis, we're going to have to start ruling out the potential for central cyanosis, which is the bluing of those mucous membranes in the tongue and bluing to the like nail beds and things like that. That is caused by a centralized desaturation of arterial blood and oftentimes will indicate some sort of cardiac abnormality or a pulmonary blood flow / respiratory dysfunction. Capillary refill is a very common vital sign that we check in these children. Make sure that you're doing it. Capillary refill time should be less than 3 seconds. We need to compare the upper body with the lower body to make sure that we don't have any differences in capillary blood flow from the upper body to the lower body. It could indicate some sort of blood flow obstruction if we do have a big difference in those. So abnormal skin signs would be a capillary refill greater than 3 seconds. Capillary refill that's slower in the lower body compared to the upper body, as I had mentioned just a few minutes ago. Mottling to the skin, which is pictured right there, where you have that kind of red, rashy looking mottling, or just pale or cool extremities. Pulses on babies, we know that little babies don't really have a neck, so we're going to check that brachial and or femoral pulse. Those should be equal between the two. They should be very easily palpable. It's kind of difficult to find brachial pulses on adults sometimes, but on babies it's very, very, very easy to find those. If you are unable to palpate pulses very easily, then consider the fact that they could have a reduced cardiac output. They could have some sort of outflow tract obstruction like coarctation, or they could have an interrupted aortic arch. If you have big differences between like the brachial pulse and the femoral pulse. And if you have large bounding pulses, remember that a bounding pulse has nothing to do with blood pressure. A bounding pulse is you're basically feeling the pulse pressure, right? You're feeling the difference between their diastolic and their systolic. So if they have a widened pulse pressure, you're going to feel those bounding pulses. And we could, or we may start to think that these people have a big PDA or a large atriovenous malformation. When assessing babies' livers, they should be just palpable underneath that right costal margin. If it's greater than 3 centimeters below that costal margin, then we have an enlarged liver. Enlarged livers mean a swollen portal system, which means typically a congestive heart failure issue. And so assessing for that liver size is always an important vital sign in these kiddos. One very rare finding that you may encounter in your career would be a left abdominal location for the liver. So these kiddos can have this Situs Inversus Totalis, which is pictured here on these x-rays. So you have the liver on the left. It's oftentimes associated with dextrocardia, the heart going into the right side of the chest. These children are generally not very sick in terms of heart babies or anything like that. Just note that this is a finding that you may see in your career. When auscultating babies, we do the liver, the fontanelles, the heart, the lungs. Bruits or bruit sounds are basically these turbulent flow sounds that you may hear over the liver or the anterior fontanelle, which indicates some sort of AV malformation. Not going to get too deep into the neurological status of the baby. I think everybody here is probably well in tuned with what a normal neuro and abnormal neuro status is for babies. But as long as babies are moving around, they've got good tone, they're crying, and they're feeding normally, then that's probably a pretty normal baby. If they are not feeding very well, they don't have a very good sucking reflex, they are irritable, in combination with having a weak sucking reflex, they also have a weak cry. They may be very flaccid. Those are all signs of poor neurological function. As far as the gestational age or size assessment of the newborn, use a gestational age based card to come up with what a birth weight, length, head circumference should be. Understand that anything outside of the normal would be abnormal. So if you have a large for gestational age baby, like infants of diabetic mothers, or if you have a small for gestational age baby, like a mom who had preeclampsia throughout her pregnancy or has some sort of chromosomal issue, then that is abnormal. Pictured here, you have a big old hypersomal baby. He was born to a diabetic mother. If you have an IDM baby, which is an infant of a diabetic mother, about 10 to 20% of the time they have some sort of large heart issue. And they do also have an incidence about 3 to 5% of the time of some other type of congenital heart defect like transposition or having a large patent VSD. The next section here is talking about chromosomal conditions. I'm not going to really get too deep into these chromosomal issues. There's probably 4 or 5 of them that they're going to talk about here. It's probably not very important for you to really be able to delve deep into these, but we'll just briefly touch on some of these. The reason that they care about chromosomal conditions is because they are very commonly associated with congenital heart defects in these babies. So the first one is trisomy 21, which is just Down syndrome. About 40 to 50% of Down syndrome babies have some sort of congenital heart defect. The most common are going to be a ventricular septal defect or an atrial septal defect. The next is trisomy 18, which is called Edwards syndrome. These kiddos are like really small for gestational age. They've got those very abnormal shaped heads that you can see on pictured right there. Generally, they're not going to live past 1 year of life, but 90% of them are born with some sort of congenital heart defect, be it a VSD or a PDA or an ASD. Trisomy 13 is another bad one that you definitely do not want your kiddos to have. Also called Patau syndrome, about a 90% incidence of CHD. You can see pictured there that this kiddo's got that cleft lip. Whenever you have a baby born with a cleft lip, you have to be conscientious of a potential trisomy 13 baby. These kiddos also have really small heads. You notice how small this kiddo's head is in relation to their shoulders. That's very abnormal for a baby. You can also have very common to have like organs on the outside of the body with these Patau syndrome babies, these trisomy 13s. Life expectancy for these kids is normally like less than a week. So very, very uncommon to transport this child to a larger center because these kiddos have such a poor life expectancy. But they do have VSDs, they can have PDAs or ASDs, any of the common congenital heart defects that are caused by these chromosomal issues. The next one is Turner syndrome. Only women can have Turner syndrome. It's where you're missing one of your X chromosomes. So this is the kid who has like the webbed neck. You can actually see right here on this picture that the webbing goes from the edge of the shoulder up the back of the neck. So that webbed looking neck is a common finding with Turner syndrome. But also they generally grow up and have like really small stature. They're oftentimes infertile. They may get pregnant if they go through intense fertility treatments and stuff like that, but very, very common to be infertile with Turner syndrome. About 1 out of 3 of them have some sort of incidence of CHD, and the most common being coarctation of the aorta, which is essentially like a stricturing of a portion of the aorta, typically like right after the ductus, which we'll talk about here in just a little while. Vater and vectoral association, I'm not going to get real deep into these two things, but essentially they're just chromosomal issues where the babies are born with like a myriad of problems. You can see pictured on the top right of your screen. This baby has limb anomalies, also has some respiratory issues. He's got an OG tube in, so he probably has esophageal atresia or maybe even a tracheoesophageal fistula. And so this is a vectoral association baby. About half of them are born with a associated congenital heart defect. And now talking about charge association, charge is just another acronym for a chromosomal issue. These kiddos can have that coloboma, which is that weird looking like hole in your iris. You know, your pupil looks like a teardrop almost because a piece of the iris is missing. And then common to have heart defects and choanal atresia and retardation or growth development. But about 65 to 85% of these charge association babies have an incidence of CHD. Most common is going to be those aortic arch abnormalities. Then you get into this page, which is talking about several deletion syndromes. Not important for you guys to remember any of this, but if you have like a baby that's diagnosed with the DeGeorge anomaly, where they're born without a parathyroid gland, they have a high incidence of associated congenital heart defects as well. All right, so getting back to the assessment, precordial activity, where you're feeling the baby's chest to look for that point of maximal impulse. Most common to have the PMI at that lower left sternal border, so that fifth intercostal space. If you have a hyperactive precordium, so it's bounding at you, or the PMI is on the right side, we need to start thinking about things like, does this baby have dextrocardia? Do they have a tension pneumo on the left side forcing that PMI over to the right? Do they have a diaphragmatic hernia, which is oftentimes going to be on the left side of the abdomen, so the stomach and other intestinal organs are up on the left side of the chest, forcing that PMI to shift to the right? Or do they have a PMI shifted way to the left, which could indicate some sort of right-sided tension pneumo? All right, this section's getting into heart sounds. It'll be interesting to see during editing if I can actually hear these heart sounds, or if you guys can hear these heart sounds, but I'm not going to belabor them too much. I think everybody in their career has learned about heart sounds, the S1 and S2 of the heart sounds. The first sound is the S1, which is the closing of those mitral and tricuspid valves at the beginning of systole. And then the second heart sound, S2, is the closing of the pulmonic and the aortic semilunar valves at the beginning of diastole. All right. So talking about S2, which is the closing of the aortic and the pulmonic valves, it's actually normal to even hear those two valves shutting almost a little bit apart, splitting of them, of the aortic valve shutting and the pulmonic valve shutting, just because of a lot of increased pulmonary vascular resistance during those first days of life as the lungs are really starting to open up. But generally, they will become pretty in sync very rapidly. Absence of one of the valves closing is obviously going to mean that there's some sort of congenital heart defect. I am personally not an expert at listening to murmurs even a little bit, and so I can barely pick up on systolic murmurs on only if they're like grade 3 or above, so they're pretty easy to hear. All right, so a heart murmur is, there's many kinds of heart murmurs, but a heart murmur is associated with blood flowing through a hole that probably should otherwise not be there. So what's pictured right here is going to be some stenosis of the pulmonary valve. So this particular one is pulmonary stenosis or just a simple valvular stenosis heart murmur. And you'll notice that instead of these heart rates going like bum, 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 and hearing a clear S1 and S2, you hear a slurring or a flow or a harsh sound basically between the two and can almost drown out the S2 sound. Then you can have a flow for a VSD, a patent VSD. These are actually oftentimes pretty easy to hear because you have this constant swirling of blood between the right and left heart, depending on which side the shunt is flowing to, if it's a left to right shunt or a right to left shunt. And depending on how big the hole is, oftentimes they're actually pretty easy to hear. This is a soft, high-pitched VSD. And then if you have a larger one, you can have this really harsh, very audible, low-pitched sound. And you can very easily hear that it's not like a bum, 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 that there's some sort of flow happening right here. Regurgitation through an incompetent valve, specifically with, you can see the sound listed down there as Ebstein's abnormality. That specifically affects the tricuspid valve, and we'll talk about Ebstein's here in just a few minutes. But that one's a very obvious, easy murmur to hear as well. Notice that you can really only hear S2. You hear a flow and then an S2 and then a flow and then an S2. That is indicative of one of your either tricuspid or your mitral valves not closing appropriately if you're hearing that murmur over the top of your S1 sound. All right, that's it for part 1. Now we are going to cruise to part 2.